Welcome back to the deep dive. Today, we're tackling, well, a public health challenge that's so immediate, so monumental, it's actually got targets from the UN General Assembly. We're talking about the intertwined threats of antimicrobial resistance, AMR, and emerging infectious diseases.
Yeah, exactly. And this isn't just about, finding a few new drugs. It feels like it's about fundamentally changing how we prevent and treat illness, really on a global scale.
We're definitely aiming high.
Yeah.
Those recent UN targets, they mandate a 10% reduction in AMR-associated mortality by 2030. That's
Ouch.
ambitious.
It really is. It's an ambition that, frankly, we probably can't meet using the tools and processes we relied on even, say, 10 years ago. The source material we've gathered provides this really meticulous conceptual roadmap for navigating this crisis using artificial intelligence.
Yeah, okay.
And we're looking at AI not just as some marginal improvement, but potentially as the next true disruptive innovation in health, like up there with the impact of vaccines and antimicrobials themselves.
Wow, okay, that sets a profoundly high bar then. So our mission today for this deep dive is to comprehensively map out AI's role here. From the individual patient right up to global research labs. We need to see the powerful applications already happening, but also, and this is important, cut through the hype, see the real concrete barriers stopping us from getting these solutions out there globally.
Right. And maybe just to set the scene quickly, when we say AI, what are we talking about? Basically, computer systems designed to replicate certain aspects of human intelligence. Things like reasoning, learning, complex pattern recognition. It's also worth remembering AI in infectious disease management. It actually goes way back.
Oh, really?
Yeah, if you look at the 1970s, you had this expert system called MYCIN. It suggested tailored antibiotic treatment regimens. So the core idea isn't new, but the capability now, powered by deep learning and these massive data sets, well, is just exponentially more potent today.
Okay, right. So let's unpack the conceptual structure our sources used. Because they didn't just list applications, did they? They grounded it all in basic epidemiology. They used the well-established chain of infection model, the 6 components needed for disease transmission, and built a framework for AI on top of that.
Exactly right. They identified 3 interconnected layers for AI application. And these map directly onto preventing or interrupting that chain of infection, moving from the sort of individual level right up to the global population.
Okay, so how does that mapping actually work? What are the layers?
Well, the first layer is clinical practice. This focuses right on the individual, the susceptible host. It's about diagnosis, treatment, optimizing those portals of entry and exit, basically individual patient care and support. Then the second layer is public health. That's the population dimension. Focuses on preventing transmission, controlling reservoirs, think epidemiology, surveillance, forecasting outbreaks, that kind of thing.
And the third layer, research, that must be about changing the fundamental tools we have.
Precisely. That layer is all about innovation. So deep pathogen characterization, developing new drugs, new interventions, really hitting the infectious agent itself.
Now, applying any AI solution, as you mentioned, it isn't like flipping a switch. Our sources outline this 5-step life cycle: data collection, model development, then clinical validation, adoption, and finally infrastructure scaling. That sounds, well, incredibly demanding.
Oh, it is.
Yeah.
And are we seeing failures at every stage? Yes.
Yeah.
Absolutely. In fact, many of the barriers we'll get into later are, simply failures to move past maybe step 1, data collection, or step 3, the clinical validation part. But look, before we get too critical, let's talk about where AI is already making a difference. Starting with that clinical practice layer, making real-time decisions that actually affect individual patient outcomes.
Okay, let's do it. Diagnostics and clinical care. We hear a lot about AI, clinical decision support systems, CDSS. What's the most compelling proof we have right now in that area?
Without a doubt, I'd say it's managing acute conditions like sepsis. Sepsis is, notoriously fast-moving. It needs immediate, correct treatment choices. And we are seeing reinforcement learning models train on just vast amounts of real-world clinical data, suggesting optimal treatment strategies. And the data showed, quite remarkably, that when clinicians actually followed the AI recommendations, there was quantifiable evidence of reduced patient mortality.
Wow, yeah, that's a huge claim. Reduced death rates based on an algorithm's advice. But doesn't this create a dependency? And critically, are these models trained on data that represents every hospital setting, or are they maybe localized to big research hospitals?
That's a really critical question, and it speaks directly to that generalizability hurdle we absolutely have to clear. We'll come back to that. But the immediate benefit in the specific clinical environments where they are validated It's profound. I mean, think about how much information a human doctor has to synthesize in seconds during a crisis. AI can help cut through that cognitive overload.
Okay, fair point. And beyond decision support, AI is speeding up actual physical diagnostics too, right? The gains in radiology seem huge.
They really are. We saw this play out during the pandemic. Tools like COVIDNet, one of the first open-source, deep convolutional neural networks, could spot cases from chest x-rays with, remarkable speed. And it goes way beyond just viruses. These models are proving highly effective in automated detection of diseases like tuberculosis, taking minutes instead of the lengthy manual review process.
And speaking of speed, the impact in the core microbiology lab sounds absolutely revolutionary. Instead of waiting days for a culture, AI speeds up pathogen identification dramatically. The detail about predicting antimicrobial resistance directly from MALDI-TOF mass spectrometry profiles really caught my eye. Can you explain that?
Yeah, that is a phenomenal advance. Okay, so before, you'd identify the pathogen, then you'd culture it, then you'd test it against antibiotics, a process that could take, 48 to 72 hours, sometimes longer. With MALDI-TOF, the machine creates this unique molecular fingerprint of the bacterial isolate. Now, machine learning models can analyze that fingerprint and almost instantly predict its resistance profile. It just bypasses that lengthy culture time entirely.
Okay, instantly. So you shave maybe 2 whole days off the decision-making process. That rapid turnaround must be critical for starting the right treatment immediately, optimizing drug use, minimizing the chance of resistance developing while I'm away.
Precisely. That speed is absolutely vital for antimicrobial stewardship. It's a game changer in the clinic.
Mm.
But if we shift focus now to that research layer, I think the potential for true long-term change really lies in drug discovery. The pipeline for new antimicrobials, as you know, it's been almost dry for decades. It's just so incredibly expensive and slow to develop new ones.
Right, that dry pipeline is exactly why this is so urgent. So how is AI tackling this huge problem?
Well, it differentiates its approach in sort of 2 main ways. First,
Yeah.
you've got what's called discriminative AI. This is essentially hyper-efficient screening. It scans massive existing chemical libraries, compounds we already know about, to identify that tiny subset that might have antimicrobial activity we somehow missed. This is actually how we discovered halicin, which works against E. coli, and abocin, which is effective against A. baumannii. These were compounds basically sitting right under our noses, flagged by an algorithm in, minutes.
Okay, so it turns this immense, tedious search problem into a targeted data problem. Makes sense. What about the second approach, generative AI? That sounds like a more fundamental shift.
It is. It's a profound leap, really. Generative AI, or Gen AI, doesn't just screen what's already out there. It uses deep learning techniques to suggest completely novel molecular structures for antibiotics. It's like inventing new candidate drugs from scratch, bypassing the limitations of our current compound libraries entirely. So discriminative AI is finding a needle in a haystack. Gen AI is designing a whole new type of needle.
That's incredible. And AI is also deepening our understanding of the pathogens themselves, right? Not just finding drugs against them.
Yes, absolutely. Tools like the protein structure prediction models, AlphaFold and ESMFold, they allow researchers to map out the 3D structures of viral proteins with just unprecedented speed and accuracy. For example, mapping the complex glycoprotein structures in the Flaviridi family that includes things like dengue, Zika. Understanding those structures helps us grasp viral evolution and identify potential weak spots for vaccine development.
Okay. So if we shift now to the public health layer, how do we move from these individual clinical gains and research breakthroughs to, population-wide protection and forecasting?
Right, this is where AI really excels at using and integrating really diverse data streams, things traditional systems might miss. For infection control within hospitals, for instance, computer vision techniques are proving pretty effective. Deep learning models can be used to monitor compliance with safety protocols, like staff hand hygiene. They can also track patient and staff behavior patterns near the bedside. This gives management instant, objective data to review, potentially improving patient safety, and importantly, without replacing human oversight, but augmenting it.
I can see the immediate benefit there for safety, for quality control.
Okay. And for forecasting outbreaks, our sources highlighted using unconventional data sources. Absolutely. The source material really emphasizes integrating streams that traditional public health systems often ignore or get too late. A fantastic example is combining automated wastewater sampling with machine learning. This was used successfully during the recent Mpox outbreak to estimate actual case numbers in a community, often before clinical cases spiked. The model showed a really high correlation between the viral bits detected in the sewage and the clinically confirmed cases. So this gives public health officials an incredibly potent early warning system, maybe days or even weeks ahead of traditional clinical reporting.
That integration of unconventional data, wow, that's a powerful nugget right there. But
Hmm.
as always, the bigger the potential, the bigger the hurdles. Let's pivot to the reality check, because achieving these breakthroughs globally means overcoming some really serious implementation gaps.
Yeah, this is where we loop back to that five-step life cycle we mentioned. And the first and arguably the biggest constraint is data quality. It's basically a failure at step one, data collection.
So why is it so difficult? It's not just about the amount of data, I assume, but how messy it all is.
Exactly. The data is fragmented. It's often sitting in proprietary silos, meaning it's not standardized. Different hospitals, different countries use different codes, different formats, different quality controls. This lack of standardization severely limits the generalizability of the models. So a model trained perfectly on high-quality, standardized data from, say, a single hospital in Chicago might just fail completely in a hospital in Lagos because the underlying data structures are just too different.
And if that training data isn't representative of the global population, well, that's where you run into huge ethical risks too, right? Algorithmic bias, especially impacting low and middle income countries, LMICs, where the disease burden is often highest.
Precisely. That bias risk is enormous.
Plus, clinicians need to actually trust these tools. What happens when a complex deep learning model spits out a diagnosis? How does the doctor know why?
Right, that's the famous black box problem. Many of these powerful deep learning models, they deliver amazing results, but they can't necessarily articulate the reasoning behind that result. Clinicians, understandably, dealing with life and death decisions, need to understand that reasoning. This is driving the whole push for explainable AI, or XAI, because opacity breeds skepticism. If clinicians don't trust it, they won't adopt it, no matter how accurate it looks on paper.
Okay, so that lack of trust and transparency feeds directly into what sounds like the second massive implementation failure hitting step 3, clinical validation and deployment. We have tons of research being published, but how rigorously are these tools being tested in the real world?
The validation gap is, well, it's staggering. One study we looked at cited a truly shocking statistic. Only 0.6%, it's 0.6% of original research papers on AI and infectious diseases reported evaluation through randomized controlled trials, RCTs, the gold standard.
Less than 1%. That is genuinely alarming. What are the consequences of that?
It means the vast majority of AI models we read about are only validated retrospectively, looking back at old data. Or they're evaluated purely on technical metrics, like accuracy on a clean test dataset. So they look fantastic on paper in the lab, but we have almost no proof that they actually improve patient outcomes or workflow efficiency in a busy, messy, real-world clinic under pressure. We're generating potentially brilliant tools, but we're often failing to apply the rigorous testing standards we demand for any other medical device or drug.
So we're developing potential solutions that might not actually solve the problem when the stakes are highest.
Okay.
And finally, there's the monumental hurdle of infrastructure scaling, particularly in LMICs. We established AI is arguably needed most where the disease burden is highest, but that's often where resources are scarcest.
Absolutely. It's a cruel irony. Even basic digital infrastructure is often lacking. For instance, one survey across African labs found that only a minuscule 1.3% had the necessary foundational capacity for just basic bacteriological testing, let alone running complex AI. Implementing these sophisticated AI models requires robust power, reliable internet, specialized hardware, skilled personnel to manage it all. It's a huge ask. This is why many experts believe the real breakthroughs for high-burden, low-resource settings might actually come from developing simpler, low-infrastructure models, things that can maybe run on minimal hardware, like a basic smartphone camera, rather than models reliant on massive server farms. The solution has to fit the reality on the ground.
Right, the solution has to fit the context. So wrapping this up, what does this all mean for you, the listener? We've seen AI offers these incredible potential advantages, driving faster diagnostics, helping personalize treatment, strengthening public health through advanced surveillance. The technology itself seems undeniably ready to help meet those ambitious UN 2030 targets.
The technology is largely ready, yes. But the infrastructure, the data pipelines, the validation pathways, the implementation strategies, they're clearly not there yet, globally. The potential for AI to truly revolutionize infectious disease management is undeniable, but unlocking it means we have to actively tackle these barriers head-on. The fragmented data, the need for explainability, that severe deficit of rigorous clinical validation, the infrastructure gap, these aren't secondary issues. They are the main hurdles stopping global progress right now.
And so we leave you with this provocative thought. The ultimate success of AI in tackling global infectious diseases probably won't be determined by the next clever algorithm. It'll be determined by human action. The long-term health value, the real-world impact, depends entirely on infectious disease professionals, clinicians, researchers, public health experts deciding to actively engage right now, to demand higher standards, to guide the development of ethical and explainable models, and to ensure that the human element remains absolutely central to how we apply this powerful technology.